Hello, and welcome to this afternoon's virtual nonpartisan briefing. I'm David Adler, Assistant Vice President for Policy at the Robert Wood Johnson Foundation, the nation's largest philanthropy dedicated solely to improving health and advancing health equity. For the past 50 years, RWJF has been a trusted, nonpartisan source of information on policy to improve health and well-being in the United States. Today, we will discuss the unwinding of Medicaid's continuous coverage requirement, a provision that guaranteed uninterrupted Medicaid coverage to millions of people in America over the course of the COVID-19 pandemic. As we approach the one-year anniversary of the start of Medicaid's unwinding, we will review the basics of Medicaid and its unwinding, discuss strategies that are keeping people connected to coverage, and explore what can be done by policymakers, regulators, and stakeholders in these final months of eligibility redeterminations. Before we dive in, a few quick programming notes. We'll have plenty of time for Q&A, so feel free to share your questions in the chat throughout the discussion. A recording of today's discussion will be shared with you in a follow-up email, along with resources referenced during today's discussion. Near the end of our time, we'll share a link to a brief survey in the chat. We appreciate you completing it. Lastly, before we begin, I wanted to make sure attendees of today's briefing are aware of a resource supported by the Robert Wood Johnson Foundation called the Congressional District Health Dashboard. This first-of-a-kind tool tracks data on health outcomes and drivers of health by congressional district. Launched in partnership with the NYU Grossman School of Medicine, the tool provides actionable, nonpartisan data on 35 measures of health and its drivers in all 435 congressional districts and the District of Columbia, and enables users to explore what's happening nationally, at the state level, and in your congressional district on specific measures of health and well-being. Later this month, new data will be uploaded to the dashboard that will contain Medicaid enrollment data by congressional district, something that is certainly relevant to today's conversation. So visit congressionaldistricthealthdashboard.org to explore the tool and find data specific to your congressional district. With that, I'd like to introduce you to today's experts. Heather Howard is the Director of State Health and Value Strategies, a Robert Wood Johnson Foundation funded program at Princeton University that helps states transform their healthcare systems to be more affordable, equitable, and innovative. She previously served as New Jersey's Commissioner of Health and Senior Services and has extensive experience working on both state and federal health policy. Edwin Park is a research professor at the Center for Children and Families, an RWJF grantee at Georgetown University, where he focuses on Medicaid, the Children's Health Insurance Program, and the Affordable Care Act. He is considered one of the nation's leading health policy experts on issues related to both Medicaid and CHIP financing. Heather and Edwin, thanks for joining us today, and I think I'll be turning it over to Heather to begin.
Thank you, David, and to RWJF for supporting this work. We can go ahead to my first slide, which is a little bit of a doozy, but you're going to get copies of the slides, and I thought this would be helpful to you all if you want to refer back to it, because this gives you a sense of where we are in the process and how we got here. So if we think back to the early days of the pandemic, January 31st, 2020 was a key date because that's when the HHS secretary declared a public health emergency. So we've got all the federal actions at the top, swim lane in the teal color. Then on March 18th, the president signed FICRA, the Families First Coronavirus Response Act, which included a temporary 6.2% increase in states' federal Medicaid match. Said basically to states, we know you're going to have greater healthcare needs that you're trying to meet, especially in your Medicaid program. We're going to give you extra Medicaid funding. But they tied that provision, that increased FMAP, to the continuous coverage requirement. They said, Congress said, we want you to keep everybody who's in the Medicaid program now on Medicaid throughout the pandemic. So tied to this determination of a public health emergency, states could not redetermine eligibility and kick anybody off Medicaid who became eligible after that date. So this is important for you to look at that top swim lane. That public health emergency, as we know, was renewed repeatedly. April 15th, 2022 was the 9th renewal. Of course, states wanted to have certainty on when this was going to end and how they could manage the redetermination process, since there was going to be a ton of work waiting for states when the time came for the continuous coverage requirement to end. So I've got here that the National Association of Medicaid Directors wrote to Congress and said, can you give us some clarity on when this is going to end, instead of it being tied to this PHE that keeps getting renewed? So late at the end of December 2022, Congress passed the Consolidated Appropriations Act and set a firm end date, said March 31st, 2023 is the end of the continuous coverage requirement. It's no longer linked to the public health emergency. So then states knew, here's when the work begins for us. And if you go to the next slide, then you get to see when states jumped into the ballgame here. And the continuous coverage requirement ended on March 31st, but not all states opted to begin doing those redeterminations immediately. So what we're showing here is giving you a sense of when different states started their redeterminations. So the states that started first are the ones that are darkest blue. Those are those 4 states that are the darkest blue. And they started to begin termination of coverage on April 1st. So we're nearing almost a year since they began. But states then started in cohorts. The next cohort of states started terminations in May. And the majority of states waited until June and July to start redetermining and terminating coverage so they could get their processes in place and do a lot of outreach. And I want to note here, too, that states have moved at different speeds as well. So some states are completing the process in 6 months. Some are taking 12 to 14 months to complete. So why does this matter? Well, it matters because it's important to sort of keep in mind the different stages states are in when you look at the unwinding data and where we are in the process, to understand that. So we're more than halfway through in terms of the number of months in the process. We're on the second half of unwinding process. But if we go to the next slide, you'll see we're about halfway through in terms of that'll be the next one, but I'll show you when we look at how many people have had their redetermination. So just important when you look at the data. One other grounding slide here is to think about what this process means for Medicaid coverage for people and the significant equity implications. If you look here, what we're showing in the left bar is that people of color are overrepresented in the Medicaid program, so therefore are at greater risk for the coverage events that are taking place when states undertake their Medicaid redeterminations. And we also know that people of color are more likely to experience housing instability. So when we're looking at things like returned mail, because people have moved and they're not living in the same place they were 3 years ago, and the state's reaching out to them saying, we need to redetermine your Medicaid coverage, and they're getting returned mail. Because of that we're going to see a cascading of these equity implications for people in the Medicaid program. Now, if we go to the next slide, it's where are we now and what are we seeing? And it's really that we know churn is common. We knew churn was common before the unwinding, but we're seeing churn sort of in a very bright light. So if we go back and think about what churn looked like, churn is when people experience a change in their health insurance status. They may be moving from Medicaid to employer-sponsored insurance or to marketplace coverages on the Affordable Care Act marketplaces, or they may be losing coverage and they may be falling through the cracks. We know that churn was common before the pandemic. Typically, within about 4% of Medicaid enrollees were disenrolling and then maybe coming back, meaning churning, coming off and coming back onto Medicaid. But that was back when states were doing routine eligibility checks. What's happening now is that for 3 years, people were in their Medicaid coverage, and then the state had to redo everybody's redetermination, the largest coverage event since the start of the ACA. So we're seeing with a really bright light this new phenomenon. Well, new phenomenon, brightly seen, what was an old phenomenon, but happening sort of on steroids because it's happening all at once in this compressed time frame. So churn happens because people might have a change in their income. Their income goes up or down. So they were Medicaid eligible and now they're not because their income went up, or their income went down and now they are. They might have a change in circumstance. A child is born or a child ages out of coverage. And so there's all those reasons still exist, but we're going to be seeing them in a much brighter light. Let's go to the next slide. So where are we now? As you see on the left of this this graphic, we're at about the halfway part in terms of how many people have had their eligibility redetermined. And again, that goes back to my earlier point about states moving at different speeds, and some bigger states maybe being later in the process. So we may be more than halfway through in terms of the number of months, but we're about halfway through in terms of the number of people who have had their redeterminations. And this is according to the latest data from KFF. As of the end of January last week, at least 16.2 million Medicaid enrollees have been disenrolled. And we know that 32 million people have had their coverage renewed. Now, based on the trends we're seeing now, the estimates are that we'll see approximately 17 million people lose their Medicaid coverage. Now, it's possible the trends will slow a bit as states continue their efforts to preserve coverage, but that's the trends we're seeing now. And Edwin's going to talk about the difference between people losing coverage for what we call procedural reasons, meaning perhaps they didn't comply with paperwork requirements, and the difference between people who lose it for eligibility and programmatic reasons. That's people who are no longer eligible for Medicaid because their income went up or because they aged out of the program. So a key thing here is to dig into the data and say, of those people who've lost coverage, how many lost it because they're no longer eligible, or how many lost it for procedural reasons and that they should still be in coverage? Let's go to the next slide, which is going to set up, I think we'll segue to Edwin's discussion, which is what can states do to minimize those coverage losses? And I put them in sort of two buckets. The first is, how can states reach out to their enrollees and make sure they have their correct contact information, so that they're not getting return mail? They make sure that when people receive that mail, not only is it going to the right address, but that people trust that mail. So one of the key strategies we've seen is partnering with community-based organizations to get the words out, because people have not heard from the state in 3 years because of the continuous coverage requirement. So you might partner with local CBOs who are getting the word out. You're going to be getting an important letter from the state. It's going to ask you to update your information. Make sure you return that letter. We've seen a couple states, Texas sent out their letters in yellow envelopes so that they would stand out, so that people wouldn't think it was junk mail. New Mexico sent them in turquoise envelopes. So that combination of frequent outreach, sometimes it was via text, or partnering with health plans and providers of pharmacies and other and hospitals, and that constant outreach and using trusted partners. The second category of strategies that I would lift up are, how can the states strengthen their own processes to make sure they're doing as good a job as they can to keep people who are eligible enrolled, so they're not losing people in that churn process? The first category here is a really important one, is do you have the right processes where you're automating things as much as possible and relying on trusted data sources so that you're not leaving it to the whims of a letter that goes out and maybe is to an old address? So that's states using things like SNAP and TANF data. If somebody's already been determined eligible for another public program, let's keep them in their Medicaid coverage. Another strategy we've seen is states have had to increase their workforce because this has been a big bolus of work that states have had to undertake that they haven't been doing for 3 years. So states have been increasing capacities at their call centers because more people are calling and saying, I got this letter, is this legitimate? What does it mean? What do I need to do? So states have had to be thinking about workforce constraints. And the final category, before I turn it over to Edwin, is states are also finding ways to promote seamless coverage transitions in case somebody's income is increasing and they're falling off Medicaid and maybe going into marketplace coverage. We've seen several states, California and Rhode Island are examples, automatically enroll people into marketplace coverage because of those transitions. Or we've seen states, for example, many states are extending coverage for postpartum for women after their delivery up to a year so that they're not losing coverage in that crucial period after a year of delivery, which has been leading to poor pregnancy-related outcomes. So there are things states can do to increase that seamlessness of coverage. And I think Edwin's going to be talking about more of those, but hopefully that sets the table, Edwin, for your presentation. And it's my pleasure to turn it over to Edwin.
Thanks, Heather, and thanks, RWJF, for putting on this webinar. So I want to do a little more deeper dive in what's happening with unwinding across individual states. So thanks to the Consolidated Appropriations Act of 2023, states are required to report a lot of detailed data related on how they are performing in unwinding. And in addition, some states have been posting some of their own data on dashboards, other public websites related to unwinding. The Center for Children and Families, where I work, has put together some interactive charts based on this federal and state data and allows for a comparison across states. And the link to those interactive charts is going to be in the resource list that's provided. So you can see here the renewal outcomes by state, and it's divided into different metrics, but the dark blue bar is related to successful renewals based on ex parte processes. That's where state Medicaid programs can use data that's already available to them to determine whether someone remains eligible and whether there's a successful renewal. In other cases, there's the light blue, which is a successful renewal based on a renewal form, information provided by beneficiaries to state Medicaid programs to determine eligibility. The red bars relate to disenrollments. So the light red bar is for those who are actually determined to be ineligible. For example, their income is too high for Medicaid now. And the dark red bar relates to procedural disenrollments, which Heather mentions, where someone may not have completed the form, didn't provide the required information, and as a result, someone gets disenrolled, not because they're ineligible, but because of procedural reasons. The last bar is this gray bar, and that's pending renewals. That's where someone has come up for a redetermination to determine if they are still eligible for Medicaid, but the process hasn't been completed. That could be because of workforce issues. That is, Medicaid eligibility workers in a state are completely overwhelmed, can't finish that renewal in the required time frame, or it could be an individual or family is seeking a reconsideration because some information or decisions made by the state have not been correct, arguably are not correct. So in the next slide, you can see completed renewals by state. So this is excluding pending renewals. And what it shows is just the incredible variation across states on these various metrics. You have some states where there's been successful renewals of nearly 90%. So Minnesota, 87%, Oregon, 86% of those going through the unwinding process continued to be eligible and they were renewed for Medicaid coverage. In other states like Texas, South Dakota, around 60% of those who've gone through the process have been disenrolled either for procedural reasons or because they've been determined to be ineligible. Similarly, the best case scenario is someone is determined to be eligible based on an ex parte process to reduce paperwork. Again, the ex parte rates vary quite significantly across the various states. Oregon, 81% ex parte successful renewals. North Carolina, also 81%. But then you have Pennsylvania at only 8%, Texas at 4.2%. Similarly, you can look at sort of the outcomes on the disenrollment side of things. You have some states where the procedural disenrollment rate of all renewals completed in the state was 55%. In Utah, Illinois was only 1.2%. Similarly, in terms of determinations of ineligibility, you have states like South Dakota at 29%, New Mexico at 2.2%. So quite a lot of difference across various states, and it may be different on the metrics in terms of who may be at one end or the other extreme of the universe of states conducting renewals. Next slide, please. So you can see here what is probably the most disconcerting result of unwinding is how high in some states the rate of procedural disenrollments. So again, this is not related to a finding of ineligibility, that is, someone's income may be too high for Medicaid in the state, but actually because of paperwork reasons, failure to complete the form, they may never have gotten the form because of an incorrect mailing address. And nationwide, procedural disenrollments are running based on data to date at about 71% among all disenrollments nationwide versus 29% of disenrollments due to a finding of ineligibility. Again, across the states, you have states as high as 94% of all disenrollments are procedural. In Utah, 93% in New Mexico, and at the other end, 7% in Minnesota, 13% in Illinois. So again, quite a big difference across states. Next slide. Now, separately, states have been required for a number of years, well before the pandemic, to report a monthly enrollment in Medicaid and CHIP. And we've been able to use this enrollment data to look at what is happening on the coverage side related to unwinding. Now, we can't tie disenrollment in Medicaid due to unwinding to a specific increase in the number of uninsured, but looking at Medicaid disenrollments among kids, you can see that Medicaid disenrollments, Medicaid enrollment has declined by nearly 3.8 million since the start of unwinding. Next slide. And here you can see state by state differences. You can look based on our interactive map about how each state's doing in terms of their coverage loss, as well as their percentage reduction in kids enrollment. Texas, unfortunately, has had an enrollment loss among kids in Medicaid of nearly 1 million. Utah has the largest percentage decline to date of 29.8%, so nearly 30%. Next slide. So what are the key lessons from unwinding so far? Again, as Heather went through, we're not fully through the process. We have a long ways to go, but there are some key lessons so far based on the data we've seen and what we've been hearing from the states. One, as the previous slides show, the state data reporting that's been required as part of unwinding, that's also been posted voluntarily by states as well, provides new transparency, valuable insight into the renewal process. It should be continued post-unwinding. So we have a good sense of what is happening in renewals every month, and there'll be a particular interest after unwinding is complete to really identify trends in states, differences across states, and areas of improvement among the states. Second, the high rates of procedural disenrollment certainly raise serious concerns. Many of those who are losing their Medicaid coverage for procedural reasons likely remain eligible. That's particularly the case for kids who have higher income eligibility levels and likely remain eligible for Medicaid but have lost that coverage. And so they're at serious risk of ending up uninsured, even though they likely remain eligible. It also means many fewer successful transitions to other health coverage. When you're not found ineligible, that also means that you're not successfully transitioned to other forms of coverage, because you just lose coverage as procedural reasons. It's not a determination that you're ineligible for because of income reasons, and therefore you should be eligible for subsidized marketplace coverage or separate state children's health insurance program coverage. If you look at increased CHIP enrollment, it only constitutes about 8% of the decline in child Medicaid enrollment. Similarly, among those losing Medicaid and CHIP coverage, federal data show that only about 13% of those losing coverage ended up successfully enrolling in a qualified health plan in a marketplace. Finally, state policies and implementation certainly matter. Wide state variation in the various metrics as I went through. State policies and implementation make significant difference, including taking up some of the waiver authorities Heather mentioned that make it easier for people to successfully navigate the renewal process, as well as states can make system and policy improvements that result in immediate improvements in the middle of this unwinding process, in the middle of the renewal process. For example, among certain states, they've seen huge increases in successful ex parte renewal rates. South Carolina went from 9% in May to 82% in November. Kentucky, 33% in May to 88% in December. So it's not too late for states to make course changes that could have serious positive implications for retaining coverage for those who remain eligible. Last slide. So what are some ways to mitigate some of these coverage losses? Just a few, and I'm happy to go into more detail about these in the Q&A, but states are required to provide 12 months continuous eligibility for children in Medicaid and CHIP. Starting January 1st, 2024. So if kids either have been successfully renewed or can come back onto the Medicaid program, they can stay on for at least 12 months. Other states, 12 states, are experimenting with multi-year continuous eligibility for young kids, 0 to 6. Some states are experimenting with continuous eligibility for adults. States can make simplifications to the eligibility and enrollment systems and procedures based on some of these results we've seen in the data related to unwinding. Targeted outreach, as Heather mentioned, particularly for those who've been procedurally disenrolled who are likely remaining eligible for Medicaid. And finally, expanded eligibility. Some states are talking about expanding their CHIP programs, postpartum coverage extensions. Those are the kind of things that could be done to not only increase eligibility, so those losing coverage can remain eligible for Medicaid, but also those kind of eligibility expansions often have a spillover effect in inducing participation among those who are eligible for Medicaid but unenrolled. So with that, I will stop and I think turn it back over to David.
Thank you. Thanks to both of you, Heather and Edwin. That was really great. We have some questions coming in, so I'll just start and see who wants to take them. Are there any resources for tracking the unwinding in U.S. territories?
Unfortunately, the territories aren't reporting the same kind of data that the states are. There is some data that Puerto Rico is reporting on its own Medicaid website about its renewal process and some of the outcomes. It's not as detailed as we would like. And among the other territories, though, there isn't good insight into what's going on with their Medicaid renewal process as part of unwinding.
Okay, thanks. Is there, I know you talked a little bit, this might be for you again, Edwin, you talked a little bit about the different implications of ways people are disenrolled and what they're likely to be able to get in terms of marketplace coverage or re-enroll and how different decisions impact that. Is there any data that's showing a correlation between Medicaid disenrollments and new ACA marketplace enrollees? And actually, it could be either one of you. I'm not sure if who wants to speak to it.
There is data on marketplace enrollment by state among those who lost Medicaid coverage, but then successfully enrolled in a qualified health plan in a marketplace. What is important to remember is that This is most successful when there's a so-called account transfer. That is, a Medicaid agency determines someone is ineligible for Medicaid, but their income looks like they are likely eligible for subsidies to buy marketplace coverage. So there's a account transfer, a lot of information related to eligibility that makes it easier for either the federal or state marketplace to successfully enroll someone in subsidies to purchase a marketplace plan. But if there's a high rate of procedural disenrollments in a state as part of Medicaid unwinding, then that account transfer doesn't happen. That person essentially is lost to the system, and they may find their way to the marketplace on their own or back to Medicaid or CHIP on their own. But those kind of account transfers, and as Heather mentioned, some of the auto enrollment features that some states are experimenting with wouldn't be triggered. And I think that may be why, as I mentioned, the enrollment rate in the marketplace, successful transitions to the marketplace, is only about 13% so far. It's definitely ticked up in the last month. It was as high as a quarter that we have data available. But unfortunately, when there's a procedural disenrollment rather than a finding of ineligibility, that seamless transition isn't as smooth.
That's really, thank you. That's really helpful. And I think that point that sort of losing Medicaid coverage or any way you lose Medicaid coverage is not the same. So the procedural ones where you're just sort of dropped is very different than saying, okay, you know, good news, you have a higher income, now you're eligible for this. And so you're just going to keep coverage. It may be a different means of coverage, but you'll stay covered. So I think that's something that sometimes gets lost in some of the conversation about churn. And so I think that's really helpful to pull out.
David, if I can jump
Yeah.
in too, and I think that's well said by both of you, that churn is common and it can be managed, right? It's built
Yeah.
into our system that people move between coverage sources. But the problem we're finding here is that they're falling through the cracks and they're not moving through in the normal ways. And I think that's really important to lift up.
Yeah. And that actually sort of, I think, ties into a question that we got as well, which is the impact of the Medicaid unwinding on health equity. And I know, Heather, you talked to that a little bit, but I don't know if either one of you want to say more about that. Oh, you're on mute, Heather.
Thank you. I mean, I do think it starts with when you start with the fact that people of color are overrepresented in the Medicaid program, then you know there's a greater risk when you're subjecting the program to these kind of shocks, right? Of who's going to be, and then when you add in that, you know, that people of color are more likely to have that housing instability and employment instability, that they're more likely, they're more vulnerable to falling through the cracks, right? And in particular, I think we worry about states are required to report a lot of data, as Edwin mentioned, but not all states are reporting that data and are disaggregating by race and ethnicity. So we don't have as much visibility as we would like into understanding those impacts. You know, so this is going to have a long tail as we sort of try and understand, as researchers try and understand it. We don't have as much visibility as we like, but we knew going in that there were significant health equity risks, and have every reason to believe that these shocks are going to be disproportionately borne by communities of color.
Thanks. I didn't know, Edwin, if you wanted to add anything onto that. Otherwise, I think there's okay. I think sort of following up on that in terms of who is going to be particularly affected by this, do we have any information? Do you have thoughts about how this changing landscape would affect pregnant people and newborns?
I'll start, but I'm sure everyone has thoughts on this too. I mean, there's good news and bad news, right? So the bad news, as Edwin showed us, is that kids, I mean, there's even horror stories about newborns losing coverage who shouldn't be, right? So Edwin maybe can say more about that. But I think there's also policy opportunities. Now more than half of the states have taken up the option of extending postpartum coverage for a year. And that's going to smooth some of those transitions. We hope that you know, traditionally Medicaid provided 60 days of coverage postpartum, and now states are providing that coverage for up to now for a year. So we're hoping that means we're not going to see people losing coverage during that critical period, because we know that pregnancy related deaths are actually happening up to a year, right? That our understanding now of pregnancy related deaths is much more nuanced, and we understand how important that full year of coverage is post. So I would point to that as a really important policy option. And, when I think more and more states are doing it, which is really helpful. But Edwin, maybe you could talk about, in particular, you all have done really important work lifting up, especially the newborn coverage losses and how shocking those are.
Yeah, there has been, reporting that in some states, particularly in the early parts of unwinding, that people who are eligible for Medicaid on the basis of pregnancy, so they're still in the midst of a pregnancy, but losing Medicaid coverage inappropriately as part of unwinding. Similarly, someone born to someone who is eligible for Medicaid on the basis of pregnancy, that newborn should be eligible for Medicaid for at least a year. And certainly there's some other states that are experimenting, as I mentioned, with multi-year continuous eligibility, so they would be eligible through age 6, but they should have been at least eligible for the first 12 months of their life on Medicaid, but were disenrolled in some states. And there's been, particularly in a state like Arkansas, that's what happened in the early months. Now, I haven't heard as much about that happening in this stage of unwinding, but certainly it has been a concern and speaks to either system errors or other errors being made by state Medicaid agencies, where someone should definitely be remaining eligible for Medicaid, renewed for coverage for some period of time, losing that coverage. And that it's critical to not only avoid those errors, fix those errors, but also ensure that that coverage is reinstated for those individuals and families, so that there isn't a break in coverage. We know how important health coverage is for early childhood development, particularly for infants.
David, if I can jump in too, I think that does raise this question of, people can be reinstated, and there is a 90-day period. And one thing we're trying to track is how states are reporting that reinstatement. No, it's unfortunate when people have to go through that, the trauma of being off and then coming back on. But luckily there are mechanisms by which people who should have remained on and who are eligible can come back on. And so that's something to be looking for, is how is something that we're trying to monitor is how states are reporting that reinstatement and people coming back in. But the policy response, I think that both Edwin and I lifted up, of course, is continuous enrollment means people not dropping out. And so this interesting option for states, in Oregon and Washington were the first states to do this saying we're going to keep all kids covered up to age 5 or 6 until they're ready for school. We want to make sure they don't fall through the cracks, so that they don't miss any of that important care and they're ready for school. So there are mechanisms for people to be reinstated, but even better, of course, is to preserve continuity of coverage through those sort of that continuous coverage, like some states are starting to do.
And one thing I'd like to add is that, you have people going through the renewal process, obviously a big burden on state eligibility workers. You have people who are newly applying for Medicaid coverage, not just those who may be trying to get back on the program after losing their coverage, but people are always becoming newly eligible for Medicaid. And then you have those who are trying to get their coverage reinstated. So there's been an inappropriate disenrollment, but there's procedures in place, reinstatement procedures, to get back onto the program, to get that coverage restored. That all adds up and puts a lot of pressure on eligibility workforces that suffered significant job losses during the course of the pandemic. And that's asking a lot, but it does put a lot of pressure. And so the worry as we head towards the end of unwinding is that there's going to be a backlog of those other actions that are needed to be taken by state Medicaid agencies, new applications, whether that volume's going up, and whether states are able to handle these reinstatement requests on the part of beneficiaries.
It's a good point, Edwin. So this work is not going to end even when we think it ends. It continues. And also, to me, I would lift up the importance, I think we both mentioned, of those partnerships with community-based organizations and healthcare providers. So how are people realizing, for example, that they've lost their coverage? so it might be when they go to the pharmacy and try and refill a prescription, right? And so does the pharmacy able to handle that, to give correct information, to maybe connect somebody with an organization that can help them navigate that reinstatement process? That's really, that's a really important touch point too.
And no, I'm glad you add that, because actually there was a question that came in about whether there's a formal end date or deadline when states have to have all their unwinding activity completed. And you mentioned kind of the timing on it. So I didn't know, Heather, you had a timeline and some slides. So I didn't know if there is a date where it's like, okay, the unwinding is done as of...
So I mean, just to go back to sort of first principles, the continuous coverage requirement ended March 31st, 2023 last year. States began initiating that work then, and they have until May 31st, 2024 to complete their renewals. But Edwin's point is a good one, is that at the same time, there's also a 90-day period. People can be redetermined, even if they finish their work at the end of May. By June 1, they're doing that at the same time that people may be newly, there's still a lot going on in the process. But keep in mind that May 31st is the last month to complete those renewals.
Yeah, individual states may go beyond that deadline. Some states had problems in their ex parte process, in their computer systems, where children were being evaluated for income eligibility based on the parents' eligibility, which tends to be lower than for kids. And as a result, some kids were being disenrolled. There's efforts to reinstate. So that sort of has led some states to make a request to the federal government that they push out that date. Similarly, other states, most notably North Carolina and Kentucky, have asked for a pause in finishing their renewals on children. So they're pausing renewals for kids while they focus on unwinding for the rest of their Medicaid population. And so that will push out the process out as well. So it, just like Heather talked about, some states started the unwinding process earlier than others. I think it's most likely that states will be finishing in 2024 at different times, just because of various state-specific factors in terms of how they've handled unwinding and other problems they've had to deal with and what they've asked for the federal government to approve.
I mean, another wrinkle that might be interesting to lift up is Michigan is an example of a state that said, we're going to take people who we know are in active treatment, like somebody who's in chemotherapy, and put them at the end of the line. So we're not redetermining them, and so that's just the example of the state, that there's so much state variation. So we often, those of us who study Medicaid, often say, if you've seen one state Medicaid program, you've seen one state Medicaid program. And I think it's probably important to come back to that as a principle, is that for folks who are listening, you're going to want to look at your own state and what policy choices they're making, because there is such variety.
Thanks. And I think the last question that we have is really looking forward about how can the data from Medicaid unwinding be used to inform future directions for the program 2024 or beyond. And you got to some of it, but I don't know if you have any sort of final thoughts about how we could be using this in terms of looking forward.
Well, I think one thing I touched on a little bit is, all states are supposed to conduct renewals on an ex parte basis, but some states are doing it really well, some states less so. And this could be, the product of computer system problems, programming issues. It takes a while to get those programming fixes implemented. And as a result, looking forward, as we're looking at renewals post unwinding, but also what we've seen during unwinding, sort of identifies problems, flaws that could be fixed to improve the ex parte process to make this renewal situation as smooth as possible for individuals and families. And similarly, high rates of procedural disenrollments, there's a number of factors. Many of them, of course, are state specific, but very high rates of procedural disenrollments does mean there has to be some issue in the system, whether it's mailing addresses not being updated as frequently, notices not being easily understood by beneficiaries about what they need to return in terms of renewal form, other information they have to submit. That sort of all identifies vulnerabilities in the system that could be addressed moving forward, so that not only do you have a smooth and simplified application process, but similarly one for the renewals as well.
And I'll add, those are great suggestions also, that we've seen states take up different strategies, and we've seen the state variation, and how do we learn from that, and what worked best, and maybe some of the temporary flex. I mean, and this is true of a lot of the flexibilities that were granted in the healthcare sphere during the pandemic, which temporary flexibilities perhaps should, might be good to make permanent. States might want to they might have the flexibility to continue. What did we do that we think was a good thing, and maybe we'll keep doing? So learning from what worked and what didn't work, and trying to sort of looking at the data and trying to map that against what new things did we do, and what have we learned that we can do better, because maybe maybe we're recognizing that churn that was acceptable before the pandemic, now that we see it under that brighter light, how can we strengthen our processes and keep people in coverage?
Well, those are definitely some things I think people will think about going forward. And I just want to thank both of you as we come to the end of this session. I think this has been really an incredible amount of information, and just a lot for people to learn from and to take in. As you both discussed, coverage transitions have really reshaped the healthcare landscape since the Medicaid unwinding began about a year ago. Eligibility determinations, as you're saying, are continuing. And it's sort of like some of those deadlines are coming, and some maybe are going to be a little bit, get pushed a little bit. And as policymakers at the state and federal level are looking at these, it is useful to see what the opportunities are to mitigate coverage losses. So I want to thank everyone, our panelists as well as our audience, for participating. We really appreciate your time and your interest in this topic. And we've put a link in the chat for a brief anonymous survey, and we appreciate you completing it to help us plan for future events. So thank you so much. And I hope everyone has a great afternoon.